Welcome again, everyone. Thank you for joining National Caucus and Center on Black Aging and the NIH, National Eye Institute's National Eye Health Education Program, NEHEP or NEHEP. We're kicking off November, the Diabetes and Diabetic Eye Awareness Month, with our webinar today on diabetes eye health, advocating for quality eye care. Our esteemed presenter today is Dr. Cheryl A. Reynolds. Dr. Reynolds is a professor at Nova Southeastern University College of Optometry and is a co-chair of the National Eye Health Education Program. So, Dr. Reynolds, thank you so kindly for joining us. We know that you're here again, once again, to educate and inform on eye health and the importance of quality eye health. Thank you. The floor is yours.
Thank you so much for having me. It's a pleasure to be back. First, I want to apologize if I look a little darker. I am in Columbus, Ohio at the hotel. I just landed, but this is so important for me to be here, and it's a pleasure to be invited back to speak to you guys and the audience about diabetes. As most of you know already, diabetes is a passion of mine. I had a family member with this disease, and so just like most of you, you may know someone that has this disease. So we're going to talk about diabetes in your eye health, advocating for your equity in eye care and for your family members' equity in eye care. And as Angela stated before, November is designated as the month to really advocate, bring awareness to attention to this disease, diabetes, and its complications. One of the things that we know is our patients that have this disease suffer from a wide array of different complications. So we're going to talk about those today. Again, these are just my credentials, and again, it's just a pleasure to be here. I just wanted to briefly kind of go over the National Eye Institute, National Eye Health Education Program, which I'm proud to be a part of as a planning group committee member and co-chair of an initiative focused on African Americans' eye health and systemic health. Is eye health, my health. Your overall body health influences your eye health. And I co-chair this committee, and NEHAP was established in 1988 to promote eye health as a public health priority and prevent vision loss through outreach and education. So I started this slide, or I did this slide on my last presentation with you about diabetes, but I know everyone on this webinar knows someone, has a family member, a coworker, cousin, aunt that has diabetes. And it's such a increasing prevalence of a disease. We're seeing more and more people with the disease. In fact, in the United States, when we look at the stats, these are the stats, but what's really profound is that half of the United States population, half, 133 million people, have diabetes or are at risk of developing diabetes. What do I mean by that? Currently, 37 million people have diabetes. That's 1 in every 10 individuals. And on this webinar, 1 in 10 of us have this disease. But what's really more important is 8.5 million people, or 1 in 5, don't even know they have it. They're walking around with this disease that can cause an array of complications, and they don't even know that they have the disease. 96 million people are on the road to developing full diabetes. These are individuals that have pre-diabetes. Interestingly enough, it's funny because sometimes I hear my patients say I have borderline diabetes, or I have just a touch of sugar. And I use that term because patients say that sometimes because they don't understand their disease. Even with pre-diabetes, it's important to incorporate lifestyle changes, exercise, eating right, resting properly, taking care of yourself, self-care, because these patients are at risk of developing diabetes. And 8 in 10 adults don't know that they have prediabetes. They're walking around, again, with elevated blood sugar levels, but are unaware of their disease. And of course, just as just to go over the disease again, diabetes is a complex chronic endocrine disorder characterized by either a deficiency of insulin secretion and or insulin effect. What do I mean by that? Type 1 patients that have diabetes or type 1 diabetes, patients don't make any insulin. They need insulin to sustain life. So they need to have insulin therapy. Type 2 is the cells over time don't work properly. So those individuals develop type 2 diabetes. So they could start off with diet, oral medication, and some of these patients may eventually need insulin therapy. And it leads to a constellation of different problems. And for our patients, there's disturbance in carbohydrate, fat, or protein metabolism. And this leads to all those complications that I mentioned before. Really quickly, I just mentioned type 1 diabetes and type 2 diabetes. But if you know someone who had diabetes during pregnancy, gestational diabetes, it's important for those individuals as well to get checked and to be monitored very closely because up to 60% of those individuals are at risk of developing type 2 diabetes within 5 years after the pregnancy. And of course, there are other common causes or less common causes, excuse me. What do I mean by that? We see younger individuals be diagnosed with type 2 diabetes quite a bit. But a lot of these younger individuals, 20, 18 years of age, may have a latent autoimmune diabetes, another type of diabetes. And sometimes if you're taking medication, such as steroid medication, that can also cause you to become hyperglycemic or develop diabetes. One of the things that we saw with COVID-19, which is a respiratory disease. And a lot of these patients were on steroid, that a lot of patients that had COVID didn't do well, of course, with their diabetes if they weren't well controlled. But also, too, there were new onset of diabetes. So one of the things that I do is ask my patients, are they still having long-term COVID or complications from COVID? Are they still on any inhalers, any sort of anti-inflammatory treatment? Because these patients are at risk of developing type 2 diabetes. And then, of course, pre-diabetes, as I mentioned earlier. Diabetes can affect from the top of the head to the bottom of the feet. I always like to say that because it's so true. Our patients with diabetes suffer from, cognitive decline as they get older, mental disturbances, depression. So it's important to really advocate for mental health awareness in our patients that have diabetes. Then for me, microvascular complication or those small blood vessel diabetes is the leading cause of blindness. It causes bleeding and damage to the eye, but not just to the back of the eye, but from the front of the eye to the back of the eye. And usually, when we talk about diabetic retinopathy, it is the leading cause of blindness in working age adult, those that are 20 to 74 young. Then kidney failure. Diabetes is the leading cause of end stage renal disease. Patients can have neuropathy, diabetes nerve pain. Diabetes is the leading cause of non-traumatic lower extremity amputation. And then more importantly, our patients that have diabetes are at risk for cardiovascular disease, myocardial infarction or heart attack and stroke. So it's really important for our patients with diabetes to take better care of themselves. But as I say to my students and I say to my patients that have diabetes, it's a team approach. It's a multifactorial. You need the doctors, the pharmacists, the patient, and the family members to be part of the healthcare system for these patients. Just to go back really quickly, the risk of early death from adults with diabetes is 60% higher than those without diabetes. I put this slide in because it's really important for me to stress. It was in 2014 that this came out, but it's still true today that every hour, every 24 hours, every day, approximately 4,500 adults were diagnosed with diabetes, 136 began treatment for end stage renal disease, 200 non traumatic lower limb amputations are performed, and approximately 641 people die from diabetes. And for me, as an eye care practitioner, 55 people become blind from diabetes every day. And race does matter when it comes to diabetes. A lot of times we hear that race doesn't matter, it's just the disease, but race does matter. We know that minority populations are disproportionately impacted from diabetes, our African American communities, our Hispanic communities, our American Indian, Alaska Native communities disproportionately are impacted. And this can be attributable to the social determinants of health, right? The food desert, health equity, insurances, financial barriers, transportation barriers, doctors not in the area, in the urban area where these patients are. So it's multifactorial, but we know these social determinants of health are really important. In fact, the diabetes standard of care 2023 really sort of addressing the social determinants of health in our patients. There's some things that again you are can control, and there's some things that you can't control when it comes to developing type 2 diabetes, right? Type 1 diabetes is an autoimmune. These children are going to get it very young. Then of course there are those that may get diabetes later in life, but they're 20 years old. Usually that's that latent autoimmune diabetes. So you want to work those patients up. But of course, type 2 diabetes, one of the biggest risk factor is obesity. And the term diabetes is really, really important because we see, especially in the southern states, your Mississippi, your Louisiana, those states have a higher prevalence of diabetes in those patients or in that population. Just lack of exercise. Sometimes they say you could be skinny fat. What does that mean, skinny fat? You could look like your normal weight or have normal weight, but you're so unhealthy because you're not eating healthy, you're sedentary. And a lot of what happened with COVID is that we sat sedentary in front of Zoom. So a lot of patients, again, developed diabetes because there was physical inactivity. Smoking is such a big risk factor. Smoking increases your risk 3 to 4 times with most diseases. Of course, other comorbidities such as having high blood pressure and cholesterol can really impact if you have diabetes, and also to the complications from diabetes. Those are things we can control. We can control our aging process. We're all growing up. We can control our genetics and we can control our race. So those are non modifiable risk factors. But the ones that are modifiable, we can control. Now, some symptoms that I want you to really understand for patients, because as I said earlier, 8.5 million people are walking around. For me, as an eye care practitioner, fluctuating vision, if your vision is changing, that could be a sign that you have underlying diabetes. If you know someone that's urinating frequently, going to the bathroom, that could be an underlying sign that you have diabetes. If you're hungry all the time, that could be another sign. If you're drinking a lot of water all the time, increased thirst, that could be a sign as well for developing diabetes. Slow healing, tingling in your hands and your feet, and of course, weight loss and fatigue. What happens is you're not breaking down the sugar, the carbohydrates that you're taking in. It's just floating around in your blood system, not being utilized. So that's why you're tired all the time. And if you have sugar just floating around in your bloodstream, you have, increased risk for infections, because if you cut yourself, bacteria likes that kind of sweet sort of environment. So you can have an increased risk of having infections as well. Now, I always put this in because I like to ask the audience, but for the interest of time, what eye condition is the leading cause of vision loss in working age adults in the United States? As I mentioned earlier, diabetic retinopathy. And one of the things that you probably will hear me say quite a bit is diabetes as opposed to diabetic patients or, diabetic individual. We're trying to make sure that we don't define our patients by their disease. So it's a patient with diabetes. So one of the things that I wrote this article for the American Diabetes Association, and we're trying to stress diabetes related retinal disease as opposed to diabetic retinopathy. Nonetheless, it is the leading cause of vision loss in our young 20 to 74 young patients. So it's important for these patients to have yearly dilated comprehensive eye exam. In this image, you could see that the patient has retinal hemorrhages throughout the retina. These yellow spots are exudative changes. There could be signs of ischemia, which are these fluffy or bigger yellow spots in the back of the eyes. And patients, this is the center part of your vision. When you're looking at me right now on the screen, you're using your macula. So you hear the term macular degeneration. In patients with diabetes, they can get fluid buildup in the macula area, and that can also compromise their vision. Additionally, this is the optic nerve in the back of the eye, and therefore patients can develop glaucoma, which affects the optic nerve because of their diabetes. But what I want to stress, and it's really important to stress, is that a lot of the patients that have diabetes are walking around thinking, oh, I don't need to go to the eye doctor. I don't need to go to any doctor. I feel good. And I just did a lecture on the silent killers. Diabetes is one of the silent killers. You feel good, you see good, so you don't want to go to the eye doctor. But you can have a lot of damage in the back of the eyes from diabetes. As you can see in this image, you can hardly see any structural changes because a blood vessel has broken and is bleeding into the gel in the eye. So if you think of the eye like a snow globe, because Christmas is right around the corner, and you shake it up and you have the flakes in the snow globe. Imagine putting red dye. That's a hemorrhage in that vitreous. So I cannot see into your eye to see your retina, and you cannot see out. And that's a lot of times patients wake up with a sudden loss of vision with diabetes because the blood vessel has broken and has bled into that vitreous. And there are a lot of patients who are just walking around with extensive damage in the back of the eye, like this picture shows, and they don't even know. A lot of patients have good vision, 20/20 vision, but can have extensive damage. That's why a comprehensive eye exam is really important. These are the other images of diabetes, diabetic retinopathy, diabetic retinal disease. You can see here in this image, the patient has early bleeds. So this will be someone who has mild, moderate changes. You might be told to come back in 3 to 6 months, observe very closely, told to make sure that your A1C is better controlled. If you are on a continuous glucose monitor like a Freestyle Libre or a Dexcom system, you might be told to know your time and range, which is a new parameter to really assess for diabetes control. And then as the disease progresses or with poor control, you could see extensive new blood vessel development. These are all neovascularization in the patient's retina. These new blood vessels are weak and they can bleed. And when they bleed, that's what causes the vitreous hemorrhage. And I just wanted to show an image of the macula. This is the macular area. This is a patient with diabetes and just a lot of exudative or lipid deposits that cause swelling in the center part of their vision. Now, what I want you to know is we talked about prediabetes earlier, and that a lot of patients don't know they have prediabetes. But do you know an eye exam is really integral in an important component in detecting diabetes? Up to 33%, a third of patients are diagnosed with type 2 diabetes during an eye exam because we dilate the eyes and we see changes in the blood vessel, and the patient didn't even know that they have diabetes. So an eye exam is not only important for monitoring if you have the disease, but it can also detect if you have the disease as well. I mentioned earlier the modifiable risk factors, and that includes your making sure your blood pressure is well under control. Blood pressure needs to be 130/80 or less. Your A1C needs to be less than 7. In fact, the American Diabetes Association recommends 6.5 or lower. Cholesterol needs to be lower. Smoking, again, is such a big risk factor. And your A1C should be checked very frequently. And if you control your A1C, even just by 1 point, if you go from 7 to 8, your diabetes risk of developing complication really minimizes. You can see that if you go from 9 to 7, you can decrease retinopathy by 63%, nephropathy by 54%, and neuropathy by 60%. This picture just shows a patient that has diabetes and blood pressure. The blood pressure was not well controlled, so you can see more complications. And again, the new 2023 guidelines, just really making sure that your blood pressure and your lipid are well controlled. I mentioned earlier about cataracts. I mentioned earlier about glaucoma and other diabetes, eye disease complication. There's so many. Patients can have fluctuating vision, double vision, blurred vision. They can have developed cataracts sooner, need cataract surgery sooner. They can develop glaucoma and need glaucoma management as well as you can get broken blood vessel or bleeding in the back of the eyes. So if you have diabetes, these are some important things that I mentioned earlier. Take your medication as prescribed, reach and maintain a healthy weight. One of the things we mentioned earlier was obesity is such a big risk factor. Add physical activity, control your ABCs of diabetes, and kick out smoking. Stop smoking. Did you know that 30 minutes of exercise can reduce the risk of diabetes by 40%? So for patients that have prediabetes, just exercising is really critically important in reducing your need for medication use. And this is what I mentioned earlier. There's such a vast part of the healthcare team that are part of the diabetes healthcare team, from your physician, your endocrinologist, your nurses, your exercise physiologist, your pharmacist, your podiatrist, the optometrist like myself, the nurse practitioner, the physician assistant, social worker, mentioned mental health, psychologists, and behavioral therapists and dietitian. We all need to communicate. We all need to share information. It's important for me when I see my patient to communicate their stage of diabetic retinopathy in the back of the eye. Am I going to refer these patients to a retinal specialist for treatment, including injections in the eye, to their endocrinologists and physicians so that the physicians know what's going on. If a patient has bleeding in the back of the eyes and they have prediabetes, it's important for me to communicate that so that treatment can be started for these patients. And again, I mentioned Eye Health, My Health. This is a resource. It's online. The web page is here. I'm co-chair of this, and this campaign is really focused on increasing awareness and education about not only your eye health, but your systemic health, and that they go hand in hand. If you're healthy, your eyes are healthy. If you're not healthy, your eyes are not healthy. But it's important to have a comprehensive dilated eye exam. Just some more information about our Eye Health, My Health program, some other resources for patients, to increase health equity that are available. A lot of times our patients don't have resources. NEHAP and NEI has various resources that are available here. And I'll share this slide with Angela so she can share with the participants. Other resources that are available. We could get free or low-cost eye care for those that have financial barriers that impact health equity when it comes to treating diabetes and diabetic retinopathy and diabetes eye disease. And of course, you can connect with the NEI on social media. I wanted to run through, and Angela, I'm going to plug up my computer because, as I said, I was in the hotel, but I wanted to take as much time as I can for Q&A. So if you don't mind, Angela, coming back on, and we'll see what the Q&As are from the audience.
Yes, yes.
Chat box.
Yes, and we just encourage our audience, please put your questions in the chat. Dr. Reynolds is one of our presenters that will even answer questions after the webinar, just in case we do not have the time to answer them. So please put your questions with your email in the chat, okay? So Dr. Reynolds, we have one here. In what ways could we slow this disease progression as individuals, communities, and as a nation? Because you were mentioning this disease is progressing at such an alarming rate that, my goodness, we could also always call it, a pandemic of sorts. So in what ways could we do that individually, communities? We know some ways, but as a nation, we seem to be needing more help to do so. So, in what ways can we do that? Because many people may not be aware of food deserts, or if they are aware, they're probably unable to avoid them because of their um, economic status.
So I think there are several things that we could do. I'm not a certified diabetes educator, but I think we need more education and more awareness, right, around the disease. But we also need better access to care. And one of the things that I stress is, interestingly enough, I'll share with the audience in Europe, in England, the rates of diabetes and diabetes related complication is going down. Why? Maybe the fact that they have universal health care, right? One of the things that we need to make sure that we do is make sure that it's healthcare is equitable for everyone. And we're in time, so I'm from Florida, so we have to be careful with words to say that there is no equity. What I'm saying is that we need better equity. When it comes to our healthcare system, better education. When my patients come into me, and they have diabetes related retinal diseases. They have diabetic retinopathy. Some of the issues is they go to the retinal specialist. And one of the things that the latest treatment is injections in the eye. But these injections, especially the newer ones that are better, are more efficacious, are expensive. And some insurance won't cover the better medication, they'll cover this medication. And I think, talking to the patient and communicating with the patient about the better treatment is important. But some doctors, they just don't inject. And then some patients, they get injection fatigue. So if they go to the retinal specialist and they're being injected multiple times, they're going to stop because it's not getting any better. My vision's not getting any better. So we need to educate them that they still have swelling, still have bleeding in the back of the eyes, and that they need more injections, and that the injection is the best treatment for patients. But one of the things that we can do, and I see this all the time. I've seen patients who've had diabetes for 20 years and they have no retinopathy. Why? They take good control of their disease. They understand their disease. They take their medication as directed. They don't listen to family members saying, oh, try this and try that. They follow up with their doctors. They take their medication as recommended. They eat healthy, they exercise, they get up and move. Michelle Obama had a move campaign. Exercise is really important. Walking is really important. We live in a society now, people get food delivered to their homes. They don't want to go anywhere. And those are the things that can impact your health and your eye health. So moving is important. Following up with your doctors, being compliant with your medication can really minimize or reduce your risk of developing those complications. Because why is it that that person who's had it for 20 years still is doing so well, while a person who had it for 4 years is struggling? And in our minority communities, we have a lot of beautiful, colorful foods. I'm originally from the islands, and so, rice and beans is important. Yes, there is this cultural part component of it, but there are cookbooks that are available for patients with diabetes that take our cultural elements into play, and we can make those foods healthier. You can make the collard greens healthier. You don't have to put all the components in the collard green. You can make the rice healthier. You could use beans and you can use brown rice, or you could use another type. You can continue to have your cultural foods. It's just a healthier way. And then, of course, I can't stress that exercise. We're seeing an increase in proportion in obesity and diabetes. The diabetes goes hand in hand. I was just in Louisiana, sweet tea. I call it sugar water, but it's a cultural favorite. And so you can have the sweet tea, just water it down just a little bit more because it really is very sweet. So you can have these things, but we really do have to watch our weight and we do have to talk to our doctors. And when you go in and you see your doctor, Angela, one of the things that I stress in my patients with diabetes is know your numbers. If you know your numbers, don't say, oh, he told me it was good. Well, what is good? Good could be 7. Now the American Diabetes Association recommends close to 6. So I say to my patients, know your numbers, ask questions, advocate for yourself. And ladies and gentlemen on the webinar, advocate for your family members, advocate for your friends and family if you're with them. A lot of times, especially with our older patients with diabetes, don't let them go by themselves because a lot of times they don't know to ask the question. You as a family member know.
So as a segue to, so you said advocate. So before I ask this other question, could you give us about 3 ways to best advocate? Some
Yeah.
of the questions, some of us may know, but we don't know. I see we have some new people on as attendees. So give us some tips, 3 ways of good questions, which would be in an advocating vein when we go and take our loved ones. I have to take someone who is now, well, supposedly borderline, but we know if that's not properly treated, what could happen. So give me or and others questions that we could ask that would say, okay, I am advocating for quality health here.
Okay.
Okay.
So yeah, so when you bring, so there's 2 components. When you bring a patient in for an eye exam, if you bring your family member in for an eye exam, to me as an optometrist, and they're there getting their eyes examined, ask the doctor, is there any signs of diabetic retinopathy? Do you see any signs of diabetic retinopathy? That's number 1. So ask them, don't let them tell you. Ask, is there any signs of diabetic retinopathy in my eyes? Number 2, will you share this information with my doctor? I will give you my doctor's information so that they share this information with the doctor. And last but not least, when do you want to see me back? In a year? I will be back in a year. If they see any stage of diabetic retinopathy, they should want to see you back sooner than a year. And if that doctor didn't say that to you, you find a new eye doctor because it's important to communicate those things to the patient that 1, they have the disease, B, the stage of the disease, and C, the follow up when they're going to come back. Okay. Now, if your family member has an eye exam and the doctor says they have diabetic retinopathy, Angela, and they need to be referred to a retinal specialist, what treatment you need to ask? Is it going to be, what are they going to do? Injections in the eye? Because one of the things is to allay the patient's fear. The patient has a fear of injection. Who wants a needle in the eye? And that's another reason a lot of our patients are apprehensive. So I have to explain that it doesn't hurt. It's the latest procedure, and it's quick and easy. And so you want the eye doctor should explain what's going to happen next for the patient. And one of the things that I do in my retina service at is I make sure I bring the patient back, even if I refer them, because I want to know A, they went, and B, they got treatment. Okay. When you go back to your primary care doctor, and if you have someone with diabetes, I said know the numbers. So, doctor, what are my numbers? What is my A1C, my ABCs of diabetes? If you have blood pressure, doctor, is my blood pressure control? Because if you don't check it at home, is it 130 or less? And they should tell you that. Is my cholesterol good? What should that number be? 70 or less? And I know you're not going to remember the numbers, but just ask number 1, what is my hemoglobin A1C? Because if he says it's okay, you should know the number. Is it 7? If it's 7, 7.4, 7.2, 7.3, well, then you know you got to do a little bit more work to bring it closer to 6. And then number 2 is how's my blood pressure How is my cholesterol doing? And then if you have complications, the next step is, if they have neuropathy and they have, lesions on their toes, should they see a podiatrist? What medications are these patients taking? You hear a lot on the news now about these weight loss medication. So for patients that have obesity and prediabetes, what are these new weight loss medications? Should I be on them to help me lose weight so I don't develop diabetes or to control my diabetes? So Ozempic, these Hollywood people are on it like crazy, but it should really be for patients with diabetes. So ask about your medication. And more importantly, speak up if your medication is causing side effects. Let the doctor know. Advocate for yourself. They can switch to a better, more well tolerated medication.
Thank you, Dr. Reynolds. Oh, so much to unpack. Um, Not the last question, but the one before, you did break this down, but I believe the question here is, how do we educate our clients, communities, especially communities of color, to slow down the progress of this disease? You did answer some before, but maybe you could highlight the education part.
So I think what you're doing for the National Caucus and Center on Black Aged and doing these webinars is important because that's the education. NEHAB's I Health, My Health is important. They also have resources for patients that have diabetes. I think, one of the things that I did with NEHAB a few years ago, one of the things that we're working on doing again is reaching where they are, right? So they're in the barbershops, the hair salons, the churches, the community centers have, community information about diabetes, education about diabetes. One of the things that the National Optometric Association does is each year we serve where you go. And we have every year during our convention, we have a mobile eye clinic and we take it to underserved communities. But part of that, what we used to do with NEHAP, and hopefully we could do it again, is we would have those individuals that came, we would have small group presentation on eye health in African American communities, on glaucoma, on diabetes, on the high blood pressure and how it impacts the eyes. So more community outreach and more community awareness and education is definitely needed. But one of the ways that we can really address this is reaching where they are, in the barbershops and the churches, but also social media for our younger patients with diabetes. TikTok has revolutionized information. Instagram has really revolutionized information. So you're asking why the numbers, because I just read, just published June of 2023. By 2050, 1.5 billion people worldwide will have diabetes. 500 million people right now worldwide have diabetes. It's a growing epidemic. And a lot of that has to do with the foods that we're eating, the processed foods. So, and lack of exercise. And COVID really kind of brought that on. So, where you are, get up and move. I think if we had that campaign again, move. If you're at the mall and you need to get a mall, just park out further and walk in. We have our fancy watches, your Apple Watch can tell you how many steps you've taken. You can get Fitbit to tell you how many steps you're taking. You can walk in place. I always tell my patients with diabetes, no excuse. Just get up and walk in place while you're watching your soap opera. Just moving is going to help. And then, like I said, doing these outreach education, which we plan on doing more with our I Health, My Health campaign, and working with you, of course, with the National Caucus and Center on Black Aging, partner with the American Diabetes Association as well, and getting the information out.
Thank you. Can eye exams detect any of the DR conditions, diabetic retinopathy?
Yes,
Yes,
that's
I thought so.
so what I will say to the audience is an eye exam is, as an optometrist, is so very important. However, I will say to you, we have new cameras, we have new imaging device, we have new artificial intelligence, right? We have all of these devices that capture a picture of your eye. And people can see the changes, the readers can see the changes, the doctors can see the changes in your eye. But there's nothing like a dilated eye exam. I did a webinar for the National Caucus and Center Black Agent on that dilated eye exam. It's really important. And like I said earlier, you can have so many changes in the back of your eyes. You can have a lot of bleeding or mild bleeding that you are unaware of because you still see 20/20 or you still see very good. So yes, that an eye exam is a critical component, not only in detecting the disease, because sometimes that the eyes are the windows into your soul. The eyes are the window into your body. We could see stages of high blood pressure, cholesterol. We could see bleeding because you have diabetes and you didn't even know it. And that's why an eye exam is important. Number two, is important if you do have retinopathy to detect it early so we can start treatment early and we can preserve our patient's sights, their vision.
Okay, thank you. Tiffany asks, in our communities, showing respect for our elders is extremely important. And sometimes the line gets blurred between being respectful and enabling. How do we assist our family members in being proactive about proactive about their health, particularly by exercising healthy eating habits while still being respectful? How would you navigate some of those difficult conversations?
With their family members? Oh my God, I'm
Oh
not.
my goodness.
Okay, let's try it. So if you have a family member, you and I talked about this, so I'll share personally. My aunt had diabetes, really bad diabetes, and not well controlled diabetes is the appropriate term. And we would have a lot of conversation. I, would take her to the eye doctor, offer her treatment, would take her to the primary care physician for a treatment, but she wouldn't stop eating sweets. And so one day we had this long conversation. I said, Aunt, close your eyes. What do you see? Nothing. And she says, what are you talking about? I said, that's what's going to happen if you keep eating a sweet because you have a lot of bleeding in the back of the eyes. So I think sometimes we have to just get real with our family members. We don't want to be disrespectful, but their health is really important. And even for me as an eye doctor, if I have a patient that has glaucoma and they don't understand your disease and you're not using your drops, I do say, close your eyes. What do you see? Nothing. Well, that's going to happen if you don't use your drops. But if you use your drops, you will preserve your sight. So sometimes a little tough love is important, making sure the patients, your family member, get checked, because if they don't, it's going to cut years off of their life and we're going to lose that family member. Also, eating, there's a lot of, um, again, these cultural ways of eating. We don't want to change it. I am not saying change it. I'm just saying do it a better way, a healthier way. Maybe having that conversation with a family member as well. And it's a difficult conversation with family members. I don't have all the answers, but we don't want to see our family members suffer. My dad was recently sick and he couldn't advocate for himself. So we had to advocate for him, but he got very bitter towards us advocating for him. And we had to tone it down a little bit with our dad and say, this is the best thing for you. We're only doing the best thing for you. So if we're taking you in the wheelchair to the doctor, it's because the doctor needs to see you. Now they can't come to the house, and he kind of understood, and then we'll take him for a little treat and he was happy. So yes, you have to navigate these difficult family members that don't want treatment or they think that they can solve it on their own.
Yes, yes. Yeah, that was great, Dr. Reynolds. And since uncontrolled high blood pressure and diabetes can be seen in the back of the eye, can these symptoms be reversed or diminished if a person's HBP or diabetes is controlled?
So yes, so if we see retinopathy in the early stages and you're not well controlled, your A1C is 14 or your blood pressure, if you made those mitigating changes to those factors, your A1C improves, your blood pressure gets better. Yes, that we could see less retinopathy. our goal really in our patient is not to see worsening retinopathy. We want it to be stable so someone can have early retinopathy for years and it's just stable, or sometimes you can see improvement in less bleeding, right? When you have high blood pressure changes in the back of the eyes, what's important is for me to educate you on the fact that you have these changes to take your blood pressure medication. Now, if a blood vessel breaks or a stroke in the eye, the goal is to make sure we get our blood pressure well controlled so you don't get another stroke in your eye, right? So, yes, once you incorporate better control, compliance to your medication, compliance to the follow-up care recommended by your treating physician, you can lessen or slow down or reduce the progression of the disease.
Thank you. Thank you, Dr. Reynolds. So I had a painful, dilated, and this personally, painful, dilated eye exam when the resident did not allow the dilation to take full effect. Give me some tips, or give us some tips on what to say or how to do that, because I remember flinching and saying, oh, just it was so painful, but there was nothing, there was nothing towards me. So what could, you don't want the could have, should have, but what was a better way of saying, okay, could we start this over, besides saying I felt that or I'm in pain?
Well, first of
How
all,
would you have navigated it?
a dilated eye exam should not be painful, right? It's not like you're going to the dentist. So I'm not sure what happened in that episode. But if you ever feel uncomfortable, if you feel like your doctor is not listening to you, if you feel that the process was not something that was impactful for you, I say the next time choose a new doctor, and I'm not sure exactly why it was painful. Maybe that doctor was rushing and was holding your lids a little bit too tight. But one of the things when we advocate for healthcare equity is respect for our patients. And respect goes both ways. Of course, respecting our doctors, following up with their care, but also the doctor respecting the patient. So in none of this, an eye exam should hurt. And again, I want to leave your audience with one thing. It's your eye health. And your eye health is very important. And if you have a doctor that is rushing, doesn't care, won't answer, it's okay to choose someone else. That's part of healthcare equity. You don't have to, I think sometimes, as minorities, I don't want to say it, but treatment may not be the same, so I used the example of Serena Williams, and during her childbirth episode, she was having some issues and she had a pulmonary emboli that the other doctors did not listen to her concerns or pain. And she called her own doctors in, and that's who saved her life. And, I say that because we talk, this talk is not about maternal health, but that's a growing concern in the minority community. So I say advocate for yourself, advocate for your loved one. I'm going to ask the audience to speak up for their loved one. Ask questions. If the doctor doesn't take time to answer your questions, I know they have a busy practice, but their staff, someone in their staff should be able to. They should be able to give you brochures and resources that you can find out more information so that you can better educate yourself about the disease.
Yes. Thank you. Thank you. So let me just say, Dr. Reynolds, that I didn't see that person again. I did not. And I believe they were residents. So yes, I do speak up. But in the moment, I felt that I didn't have a recourse or a way of saying, because I said, oh, that's painful, and nothing was done. But yeah, that
you have a recourse, and I think I want you to take power back into your own hands, and then I'll stop pontificating. Patients always have some power, and I feel like especially the minority community don't feel they have power, and that's why this disease disease, again, is more prevalent in certain populations. You do have power. Speak up for yourself, and I speak up for your loved ones. And if that doctor didn't hear you, maybe going back and letting the doctor know, maybe he didn't hear you at that time, it's rushed, or choosing another doctor is totally fine. And I advocate that. Like, I've had patients who say, I won't go back to that retinal specialist. All he does is injecting, he's not talking to me. And then I'll say, you have the right to go to another retinal specialist that's going to talk to you as to why the injections are important, to continue the eye injections to treat your diabetic retinopathy.
Thank you again, Dr. Reynolds. If you have any more questions, put them in the chat. Dr. Reynolds is doing a talk pretty soon, so we will not belabor the point. Thank you, Dr. Reynolds, so very much. We do appreciate you at all times that you come. You're here for us. You're here to, again, inform and educate and give us the information. Tell us what's going on and how to advocate for ourselves, as this webinar was. We appreciate you. We thank you so much. Thank you, everyone, for coming and joining us. And we wish you a good afternoon and the rest of your evening. Enjoy it. Dr. Reynolds, good success on your talk coming up at 2 o'clock. We thank you and we give you back your afternoon.
Thank you so much for having me.
All right. Thank you. Bye-bye.